right, so we're going to start with acute pancreatitis. So we'll start off with what your pancreas does. Your pancreas helps with digestion. It secretes insulin. I am not technologically ready right now. And it secretes digestive juices and enzymes, so your amylase and your lipase, and there's also trypsin. So your amylase helps to break down starches, your lipase is used to break down fats, and then trypsin is used to break down proteins. And all of these things are going to be broken down in the small intestine. Oh, it's ahead of myself. Okay, so pancreatitis, acute pancreatitis is going to be an inflammatory process. You can have mild edema to severe necrosis. So there's your mild edema and necrosis. So edematous pancreatitis is mild and self-limiting. Your necroticizing pancreatitis, the degree of necrosis correlates with the severity of your manifestations. So acute pancreatitis affects more men. And it affects more men it's common in middle age, and it also affects more African Americans. And then I think you go to Y after this. So some of the causes of acute pancreatitis, you've got alcoholism, you've got gallstones, because your gallstones can get stuck right here and block this little duct, and that's how you have one of the issues of acute pancreatitis. So that's your gallstone would get stuck like right here. So normally in the pancreas, it's secreting these enzymes to go into the small intestine, but when you have anything that's disrupting the normal function, you're going to have your enzymes actually activated in your pancreas, your amylase and lipase, instead of in your intestine. And then you've also got trypsin that's being activated as well in the pancreas, and the trypsin actually starts to auto-digest your pancreas. Are you okay?
Yes.
Oh, okay.
Sorry, I was going to press the button.
Oh, okay.
But you can't miss.
That button. So you've got your amylase, lipase, and trypsin that are supposed to be in your small intestine, and instead they're not. They're staying in your pancreas because it's damaged, and they're basically eating the pancreas. There's other causes of acute pancreatitis as well. It can be trauma to the abdominal wall, viral infections, penetrating duodenal ulcers, cysts, abscesses can also cause acute pancreatitis. Viral infections can cause it. Some drugs like corticosteroids, sulfonamides like Bactrim, and NSAIDs can also cause acute pancreatitis. I don't know if that's all on here. No.
What does it say? What does it mean when it says the auto-digestion? Is that related to
So think about it. Normally, your pancreas excretes the amylase lipase into the intestine, right?
Yeah.
It excretes it to digest food. Well, now you have this, either some alcoholism that's damaged the pancreatic cells and it can't excrete, or you have this gallstone that's blocking it and it can't excrete. So now instead of that amylase and lipase being in the intestine to break down food, it's in the pancreas and it's breaking down itself. So now you get this auto digestion of the pancreas, you get damage to the pancreas because these enzymes are not working where they're supposed to be working. Instead of going into the intestine, it's just auto digesting itself.
So then it says activated trypsin not blocked?
Yes, so trypsin should be blocked, but because it can't be blocked because the enzymes aren't where they're supposed to be and they're working, that's what increases the risk for hemorrhage. Because you have the pancreas breaking itself down and you get this increased risk for hemorrhage.
And that says digest what? And that causes hemorrhage? Pancreas?
Auto digestion.
No, it says trypsin not blocked.
Activated
Digest.
trypsin's not blocked, so it digests the pancreas,
Pancreas and
causing the
hemorrhage.
hemorrhage.
Okay.
Yes.
How come with like the alcoholics, the pancreas, is that usually affected first and then the liver, or like does the liver kind of go through that thing too?
I don't know if one's affected more, like which one comes
Because I always
first.
see like the pancreatitis with the alcoholics, the
Yeah.
acute pancreatitis.
It damages their liver because that's where it's getting processed, but it also causes damage to the pancreas because it injures those cells. Oh,
It
go ahead.
no, it increases the digestive enzymes, the production of the enzymes. So
It
it's
increases them, so that it's just working harder like than it
Yeah.
normally would. Okay.
Yep.
But whether one comes before the other, I don't know that answer. I don't think there is an answer. I don't think
Okay.
failed liver comes before failed pancreas or vice
Okay.
versa. But they just, there's damage to each of them.
Okay.
So some clinical manifestations of acute pancreatitis. Let's get that. You're going to have pain, abdominal pain due to distension of the pancreas. The pain's going to be located in the left upper quadrant or mid-epigastric area. It can radiate to the back. And it can be a sudden, deep, piercing pain. Can be aggravated by eating. And then the pain is frequently onset when you're just like in a resting position. So you'll see a lot of these patients are doing frequent position changes just to try and get comfortable. It's not relieved by vomiting. Ugh. Some of your other manifestations that you're going to have with acute pancreatitis. Well, that's your change position. Are flushing, cyanosis, difficulty breathing, which is dyspnea. There's your nausea and vomiting. You can have a fever, leukocytosis, which is your elevation in your white blood cells. Tenderness in your abdominal area. You can have hypoactive bowel sounds or absent bowel sounds. And then some of the patients will have, they're called gray Turner spots, and they result from leakage of the blood-stained exudate from the pancreas. So you'll see bruising in the flank area. Those are your gray Turner spots.
They're on the skin or on the...
You can see them on your skin. You can have Cullen sign, which is a bluish periumbilical coloring, so that's going to be around your belly button. And again, those are something that you can physically see on a patient.
the breathing dyspnea cyanosis?
The breathing, I would say probably from the pain. What else did you said? The breathing, flushing.
Cyanosis.
The cyanosis, I'm not sure.
Because they're not breathing as well. So imagine them, it's every time they take a breath, it's really sharp, it's really uncomfortable, so they tend to kind of, they get in all these different positions, and they kind of scrunch together. They're not taking nice deep breaths, so they're not getting that full expansion of the lungs. The alveoli kind of collapse, they're not getting that gas exchange, and they can develop that.
And then we move on to complications of acute pancreatitis. You've got a pseudocyst. It's not a true cyst. It often forms after injury to an organ. It's surrounded by fibrous tissue. It's thick and scar-like, and it's filled with pancreatic debris, enzymes, blood, and fluids. These often form after a bout of acute pancreatitis or abdominal trauma. They can cause abdominal pain radiating to the mid-back. Let's see here. So filled with pancreatic debris. So you'll see abdominal pain, nausea, vomiting. Can you feel the mass with the pseudocyst?
Not typically.
Or just see it on like a, okay. So if your pseudocyst becomes infected, you can end up with an abscess. So then you have your pancreatic abscess. Oh yeah, felt as a palpable mass and seen with a CAT scan. So you can feel the pseudocyst. So pancreatic abscesses, you'll have an increased fever, leukocytosis, abdominal pain, and these are usually large fluid-containing cavities resulting from extensive necrosis. It can lead to shock. So the abscesses are the ones you have to have removed. The cysts they can watch. Yeah.
Sometimes. Yeah, because they don't want it to rupture and then get all those contents into the abdomen, causing that peritonitis.
Okay. So some diagnostic studies. We've got obviously our history and our physical examination. Some of the lab tests you're going to do is you're going to check amylase and lipase, and those are going to be elevated. You're going to check blood glucose, which is usually elevated as well because your pancreas is what secretes insulin. Serum calcium is going to be low. And there's no real good, the only thing I could find is that might be related to low levels of albumin, but what you want to watch for as a nurse is tetany, and it's kind of like that, is it when you have like this and you twitch? Yeah, it's kind of like a twitching from the low calcium.
Did you say albumin's low?
Yeah, but I don't think you guys just need to know the calcium's low. The albumin's kind of just like a side note. You can check the serum triglycerides, which are going to be high. And then a CAT scan is the best imaging exam for pancreatitis, but you can do CAT scan, MRI, or X-ray. So our goals for patients that have acute pancreatitis are to stop the cause. We want to relieve pain. We'll keep them initially nothing by mouth. Sometimes they need an NG tube to help suction out secretions or to help keep the secretions down. We can give IV fluid, lactated ringers is what you would want to give. We can give vasoactive drugs. I don't know if I had that on here. And then there's your albumin in your blood that we can also give. We want, if, once they're able to eat, we want to do small meals, bland diet, high carbs, high protein, low fat. High carbs are good because they're least stimulating to the exocrine portion of the pancreas. And then a low fat diet helps to reduce steatorrhea, which is the fat in the stool. And there's your vitamins A, D, E, and K. And these are given because fat is being malabsorbed. And vitamins A and E help to reduce inflammation. They can do TPN if it's necessary, and then with the TPN you want to monitor the triglycerides because they're already going to be high. I don't know. Then we can give antacids as well, like Tagamet. So Tagamet and Prilosec help to decrease hydrochloric acid secretion because the hydrochloric acid stimulates pancreatic activity. You've got your PPIs, your Prilosec. For pain, you can give morphine. Your antispasmodics. You've got something like Benton. Thank you. I can't speak. That helps to decrease motility and pancreatic outflow. And then antibiotics, if you need them. And then they can also do a lap chole if this is resulting from a biliary issue.
You guys know what a cholecystectomy is? Where they remove the gallbladder? Yeah, you do? Good. Okay. Yeah. So if the gallbladder is the cause, if you have gallstones blocking, then let's take them away. So we might have to get the lap chole to take away the gallstones. Helps resolve the issue.
Do you guys?
Yeah.
If pancreatitis happens because the enzymes are being produced inside, they're not coming out of the pancreas, basically, and they're eating it. If we feed them carbs, aren't we producing more enzymes and then we're creating a bigger problem?
No, because what the pancreatic enzymes break down.
What? The beef?
So if you've got more of the pancreatic enzymes, they're breaking carbs down like there's no tomorrow. So you want to make sure they have carbs. Because if you're...
They break carbs down if they come out of the pancreas to the small intestine.
They break down fat. Let me make sure I'm telling you the right thing.
Well, if the amylase is elevated and you're giving them high carbs, is that...
I will come back to you on that question. We'll move forward and I'll come back. Yes. So that we don't stop that.
Okay.
For the steatorrhea, would the fat soluble vitamins help that? So you don't have fat in the stool?
Yeah.
Right, okay.
And also, on a note, I'm sorry, just to go back because you smart students pointed out to me, I said radioactive before. We are not giving our patients radioactive materials. I meant radio opaque, meaning that. So thank you for the person who corrected me as I misspoke. It's radio opaque so that they can see it via the x-ray. And then another student found that it highlights the defective area. So we were, like I said, I wasn't sure, but they did find that when the radio opaque, not radioactive material that we give them is digested and we do an x-ray, we can actually see it looks dark. So, or whited out basically on the x-ray. So you know how an x-ray is black and we can see white bone or airspace is black? With the radiopaque material, when it gets to the area that's, diseased or defected, that area will like kind of light up in a bright white. All right, that was back with the other stuff. And I will look up with the high carb diet for you, Naveen.
That was the barium, right?
Yeah,
the
the
barium
barium.
study?
Mhm.
Okay. So chronic pancreatitis is a continuous, prolonged inflammatory and fibrosing process.
Is it continuous control?
Continuous. Continuous and prolonged. So there's two types, chronic obstructive pancreatitis, which would be your gallstones, and then chronic calcifying pancreatitis, which would be chronic inflammation of your pancreas. So chronic pancreatitis can follow acute pancreatitis, but it can also occur without any history of acute pancreatitis. And again, it can be from acute biliary disease. Or idiopathic, from out of nowhere. Okay. Clinical manifestations of chronic pancreatitis, burning, cramp-like, can be chronic or reoccurring at intervals. A heavy gnawing feeling. Your pain's not going to be relieved by food or antacids. You'll see malabsorption with weight loss. You can have constipation, or you can have steatorrhea. You can see mild jaundice with dark urine. And then with chronic pancreatitis, a lot of these people do have diabetes.
Could you please repeat the first clinical manifestation? It's written right there, sorry.
Oh, burning, cramp-like, chronic, or reoccurring at intervals.
Thank you so much.
You're welcome. So some of the diagnostics, some of the lab tests we're going to do, we're going to test the amylase and the lipase, which again are going to be elevated. Your bilirubin is going to be elevated if there's a blockage. There's the little gallstone hanging out there. It's going to elevate your bilirubin. Your ESR can be elevated, which is your erythrocyte sedimentation rate. And that's a non-specific measure just of inflammation. Your glucose is going to be elevated. Your alkaline phos is going to be elevated, and that's a lab test that shows how well your liver and gallbladder are functioning.
Did you say alkaline phosphate?
Yeah. I just have alkaline phos. Yeah, phosphatase. Do you want me to spell it?
No.
Okay.
Thank you.
You're welcome. You can do x-rays to show fibrosis and calcifications. Your vitamin B12 level is going to be decreased. So your fat soluble vitamins are going to be decreased. That's why they want you to take the A, D, E, and K. And then you can also do an ERCP, which is endoscopic. So what that is they'll go endoscopically go down and visualize your pancreatic and common bile ducts to see if there's any blockages or what the problem is. They can also do MRIs and ultrasounds. So treatment for chronic pancreatitis. Initially, they're going to be nothing by mouth. They can have an NG tube to suction. We want to give IV fluids, preferably lactated ringers. Sometimes our patients need blood and albumin. For pain, we want to give them IV morphine. Fentanyl's on here, but that scares me. Okay. We want to treat the diabetes with insulin. We want to teach them to try and quit smoking and stop drinking. Again, we're going to do the bland, this says low fat diet. Small frequent meals. And then you also want to replace the pancreatic enzymes. So it's pancreolipase they'll usually give with meals for the patients that have chronic pancreatitis. Do you guys have any questions about acute or chronic pancreatitis?
Did you say who it was for the chronic pancreatitis? Or
The-
is it the same as the acute?
It can be from acute or it can be from it's still going to be the same kind of people.
I
It's
think that's
just,
the question.
she was asking if it was the same people who get the chronic.
Yeah,
Thank you.
it's basically this acute phase is prolonged and it causes that fibrous tissue.
Okay.
So
That's all. Thank you.
Alright, so cholelithiasis and cholecystitis. So cholelithiasis, those are going to be the stones, your gallstones. And cholecystitis is going to be inflammation. Okay. So the function of your gallbladder is to concentrate and store bile, and bile is produced by your hepatic cells, which are in your liver. So the bile will exit your gallbladder and goes into the duodenum, and the bile is needed for fat emulsification and digestion. So cholelithiasis is going to be the most common disorder of your biliary system. And again, that's going to be the stones. With your cholelithiasis, just with the stones, the incidence is higher in women, usually over 40. It's also more common in Asian Americans and African Americans, and it's especially high in the Native American population. They think that oral contraceptives increase the risk because the contraceptives affect cholesterol production, and they increase the likelihood of the gallbladder cholesterol saturation. I don't think that's on there, though. No?
No.
Okay. So with stones, they can be asymptomatic. And then if you do have a stone that becomes lodged in a duct, you can get spasms, and those are called biliary colic. And they can cause excruciating pain for greater than an hour. You can have residual tenderness 3 to 6 hours after a heavy fatty meal. Heartburn or flatulence. And then you can also have fat intolerance.
You're excruciating pain after an hour,
I would lasting up to an hour or greater than an hour.
I'm sorry, I wasn't listening to you.
Your stones with your pain for more than an hour.
Yeah. More.
It's an hour.
Did I say up to an hour? What did I
It
say?
says in the
You
notes
said
up
greater
to an
than.
hour in the PowerPoint.
Yeah, it's okay. Excruciating pain lasting up to an hour.
I'm sorry, I'm trying to look up the pancreatitis, and everyone is just saying that,
It's
yes,
really
it breaks down carbs. But they're more concerned because it's breaking down the fat, and the high fatty meals is what's caused all that problem with acute pancreatitis. So they want the low fat, high carb diet. But no one can really explain why high carbs. I'm looking up all the different med journals right now.
Well, carbs are protein sparing, number one. So a high carb diet would spare their negative nitrogen balance
Oh.
on protein.
I'm gonna go with that's not on the
Spare the
test.
muscle mass.
Yeah. Yeah, but yes, you're right. That is a good answer. That's true. So the carbs are easier to digest, but the body doesn't cause as much byproduct, and doesn't cause as much. It's not as hard for the body to break it down, basically. Mhm. Sorry, I can't.
Unfortunately, it stimulates insulin.
Can also have difficulty breathing.
Yeah, that's what I'm trying to figure
most likely related to the pain. All right, and then with cholecystitis, which is inflammation, it's backwards on here. You've got indigestion can be a clinical manifestation. Mild to severe right upper quadrant pain that can be radiate to your shoulder and your scapula. Fever, leukocytosis. Jaundice. Nausea, vomiting. Diaphoresis. Pruritus. Is that from the elevated bilirubin, the pruritus?
Yeah,
Which is
because it's
itching.
deposited in the
Yeah.
skin and it
Your
itches.
skin itches, that's pruritus.
Think of the inflammation as like an infection. Their gallbladder is kind of infected, so they're gonna get that high white count. They're gonna get a fever. They're gonna, be sweating. And because the gallbladder's being blocked and your Billy levels are high, that's when you get the yellow and the itching.
And then you can also have dark urine. Is that clay stools?
Mm-hmm.
Do you need to see the other? Are you guys okay? Or
That's okay.
Okay.
If you move forward, it'll be on there.
so some of the diagnostics we use, we always want to do a history and physical. Oh, let me go to this other one. History and physical. Ultrasound is commonly used to diagnose. And then you've got the ERCP again. So this will show the gallbladder, the cystic duct, the common hepatic duct, and the common bile duct. And then you can also place stents when they're in there to dilate the duct.
The ERCP is really kind of cool. It's like doing a cardiac cath for the heart, or like we talked about, like for coart, where we go in there and we just kind of spread, put a stent in and open it up. It kind of gets put in, opens it up so that the stone can either pass through easier, or they can kind of clench it and pull the stone out.
Tricky procedure.
Yeah, it's tricky, very tricky procedure. Dr. Wilde at All Kids is phenomenal with it. And it's really cool once they pull out all the little stones, because they look like nerds, actually. As I'm sitting here eating them. They're like little hard black nerds. Probably like a large nerd.
What is the open sphincter of?
Don't worry about all that, that's just kind of,
Fun fact.
yes.
So with lab testing, you're going to see abnormal liver function tests. They're going to be elevated. And then you'll also see increased white blood cells as a result of the inflammation. Do they need to know cholangiogram? Because that's on here. Okay. And then your bilirubin will also be elevated. And your amylase will be elevated as well. So collaborative care of the patients with gallbladder disorder. We're going to do pain control. We want to do infection control if, we want to avoid a rupture or an abscess or peritonitis. Give them IV fluids. Gastric decompression. That would be again with the NG tube. Initially, they're nothing by mouth, and then we can progress them to a low-fat diet, small meals. Anti-nausea medication. And then here's your fat-soluble vitamins again, A, D, E, and K. And then you can give Questran for pruritus. It's that powder that I don't know if you've ever seen them mix it in like juice for the patient to drink. You can do shock therapy, but just on the stone.
Like lithotripsy.
Yeah.
They don't really shock them.
No, just the stones.
Yeah. And with lithotripsy, unfortunately, it only works well for thin individuals because the waves can only go so far. So if you have a obese individual or a certain percentage of fat, they can't do it because the waves will get kind of absorbed by the fat before they get to the stone. And the whole purpose of it is they send this kind of shock wave and it goes in and just and just like breaks up the stones into a smaller piece so that they can be passed easier. It's my very technical term.
So if they're small enough, they can pass.
If they're
them.
small enough, they can pass them. Or like, sometimes they're small, but they get clumped together and the lithotripsy just kind of, and like, so that they can kind of fall out, of not being stuck together. Or take a large stone and just break it up into smaller stones so that they can pass. But again, it's only certain individuals that they can do it on.
So at the shock therapy, you'll usually find that they also are giving them Acticol, which helps to dissolve the stone. It'll dissolve the cholesterol in the stone.
How do you spell that? I'm sorry.
Actigall. And then we can also do a lap chole. We can just take it out. And the lap choles are easier to recover from than the open choles. Cholecystectomy, sorry. My gosh. And that's it. Do you guys have any questions about gallstones? Thanks. I have cahoots. But only 11.